Good evening, everyone. Welcome to the fifth session of Child Mental Health Community of Practice, Assessment and Management of Mental Health Disorders in Neurodiverse Children and Young People. We'll start the session by the acknowledgement of country. Northwest Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon Wurrung people, and Wadawurrung people. We pay respects to elder, past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Some community of practice guidelines before we formally start the session. So here we agree to stay on mute unless speaking. Raise your hand to speak. Keep conversations confidential. If possible, please keep your camera on. Introduce yourself and your role when speaking. Please share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests, and ask questions because no question is silly. During the education component, please ask questions via the chat box. This session is being recorded, so please ensure you join the session using the name you registered with so we can mark your attendance. Certificates and CPD will not be issued if we cannot confirm your attendance. Something about how to change your name in Zoom meetings. So click on participants. If you're joining through an app, click on your name. If you're joining through desktop, hover over your name and click the three dots. And from Mac, click over your name and click more and click rename and enter the name you registered with so that we can mark your CPD. Our psychiatrist, Dr. Prakash, he is a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked extensively with kids and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha. I'm a GP who works in Sunbury, and my areas of interest are child and adolescent mental health and chronic disease management. And our guest speaker for today is Dr. Billy Garvey. Dr. Billy Garvey is a pediatrician with nearly 20 years experience. He is a specialist in both the Center for Community Child Health and General Medicine Department at RCH. He's an expert reviewer for the Raising Children's Network, contributes to RCH clinical practice guidelines, and he is a reviewer for several academic pediatric journals. He's currently undertaking a PhD piloting a model to support child emotional and behavioral development in primary schools, and he is a Churchill Fellow exploring how social media can be used to support parenting. He's also the founder and co-host of the Pop Culture Parenting podcast, which aims to support the child development and well-being using evidence in a meaningful, fun, and realistic way. So I'm just going to hand over to him so that he can present the education component of today's session. Thank you, Dr. Garvey.
Hi, everyone. I've got some slides. It's amazing to be talking with you all. I can see people just don't really have cameras on, which is totally fine if you don't feel comfortable, but I'm going to try and do it a little bit different to how you normally will. So if anyone feels comfortable, I know for a lot of us it's at the end of a long day, but it'll just make it a bit more helpful if we can chat during my talk. So as mentioned, I'm one of the developmental paediatricians at the Royal Children's Hospital, but I really enjoy the chance to just work more broadly with groups. I was asked to speak about assessment and management of mental health disorders in neurodevelopmental children and young people, which is a common thing that all of us in this group probably see. So I'm hoping it's going to be helpful. This is what the session will look like. The photo of me, if anyone has seen me do a talk, is in most of my talks at the start, just because I really love the sound of my own voice. But the point is for not just me to talk. If you only feel comfortable putting comments in the chat, that's totally fine. But if anyone feels comfortable, I'll ask some questions during it. Please feel free to put your camera on and unmute and talk. I'll make some awkward silences to see if I can promote people to do it. It's just a lot richer when we hear from the whole group, not just me. And also just stop me during any time in it as well. I'll keep an eye on the chat as well. So we're going to start and just quickly talk about a group agreement. I'm trained in a facilitation model that I really think is helpful to try and move away from me just didactically talking at you. And then we'll kind of wrap up at the end and then go into the cases. I think it's really important to just, normally when we'd facilitate any groups, we would talk about what are our shared agreement for this and kind of what are our principles. I think it's important that all of us, especially after the end of a long day, are giving up our time to think about how we can do this better, and just making sure that everyone feels comfortable that there'll be a diversity in opinions and things might come up, but we're just all really respectful and trust each other, and we're patient-centered and confidential. I think the curiosity bit that comes from a lot of groups is really important. We're all just curious as how we can do this better. And then the shared responsibility bit, I guess, is sometimes when I do these talks, I kind of go, God, it was just me talking the whole time. I'm not sure if that was actually helpful, but I would benefit from everyone in the group taking a bit of responsibility for how well this goes as well. And just thinking about how we can make sure that that happens. So this is the scene. People might have seen this before. This is kind of pre-pandemic data now, but the best data we have nationally on why kids will see a developmental paediatrician or a paediatrician in hospital, community or private practice settings all around the country. And as you can see, the majority or 8 of the top 10 diagnoses fit into what we call neurodevelopmental. I think it's important to also have with that the idea of how many of those kids, sorry, my Mac's playing up, how many of those kids will also be seen on the AEDC data, which is the table on the right at school entry and prep. Nationally, every 3 years, we collect data. We collect, I think, 90% of the data on preps entering school in their terms of developmental concerns. And 2021 was the last wave, which showed that there has been a slight increase in the amount of kids entering school with developmental concerns. And as you can see, there's a big overlap between that and what we all see in clinic. So it's just thinking about how we can identify these kids more accurately and sooner, knowing that that's where the evidence is. I think it's really important that we have some kind of background understanding of what we mean by neurodiversity, and we all have maybe slightly different interpretations of this, but I'm sure anyone who's experienced any time in the advocacy of this space will know that it's really important that inclusive language is used. I think sometimes neurodiversity can clash with traditional kind of old school medical approaches that are very deficit based. We might end up talking a little bit about the DSM-5 and how there can be some conflict in, looking for what kids are failing at and trying to diagnose them versus neurodiversity, which is really about, a movement that started in the 90s, thinking about actually we're all just have different ways that our cognitive processes will take in information from the world and then think about it. When we're talking about neurodiversity in a clinical setting, we're often thinking about the children that we see who may have diagnoses such as autism, ADHD, dyslexia, other learning difficulties, and sometimes that will move into psychiatric diagnoses as well. But the main point of this talk today will be of those kids that we see in those top 10 diagnoses. We'll mainly focus on autism and ADHD because they can be really helpful for kind of thinking about a lot of the kids we see in clinic that might be vulnerable to mental illness being missed. If anyone has any points or comments, as mentioned, please stop me. So I think this is the balance that we walk in a clinical setting of, neurodiversity versus neurodevelopmental disorder. And I wonder if anyone in the chat or feels comfortable putting their camera on and taking mute off and speaking about their experience or how they focus on this. I'll give a little bit of awkward silence to if anyone does, but I guess the challenge is how do we face this as clinicians when neurodiversity and inclusion is something that in a good way is becoming more prominent in our community, but we have to struggle with, making sure we abound within the medical practice, but also considerate of that. Does anyone have anything they feel comfortable putting in the chat or unmuting their mic? It's obviously totally okay if no one does. It's just that all you'll hear from is me then.
Billy, it's
Hey, Lyndall, how are you going?
Yeah, I'm good. And, this is a framework that I often don't use, so it's making me think about things. But the DSM often talks about the social impact or how much the functioning of a young person is impacted. So when I see the word disorder, that's more what I'm thinking, because both can be neurodiversity, but is it to a degree where their day-to-day functioning is significantly impacted? And I'll just add a final comment. I love this terminology, but I hate when we have to go from this terminology to the NDIS model and we're talking about disability.
Yes. I'm not covering much of the NDIS because I'm like you, Lyndall. I feel like I'm in a fight with the system the whole time when I'm working with the NDIS. But yeah, yes, and Vivian, you're right. As Lyndall was saying, the problem is that the funding is based on how poorly the child is doing. And we have this balancing act of like kids that come in that are all beautiful and unique. And we know how important it is in the narrative that we celebrate them, but we're sitting there scrutinizing all the stuff that they're failing at. So it's a challenge. I'm a bit like Lyndall, probably because Lyndall helped me learn about this stuff, thinking about, where is the functional impact? And I think it's a really important thing that we can, in a helpful way, think about the functional impact of either, the element of a diagnosis that might be there, and obviously thinking about how a diagnosis can help us. And I think all of us probably feel comfortable in that way in, a diagnosis of autism or ADHD, but we should also, when within those kids, we're exploring the possibility of a mental illness such as anxiety or depression. It's also a really good way, I find, to lean into a patient-centered approach. So, they could be doing better at this. I feel like they're really struggling with their friendships. They seem really anxious in certain environments. They are quite, they're having a lot of challenges socially. And I don't think it's just, the fact that they, think about social relationships a bit different. There might be something else going on. What do you think? So I'm the same as you, Lyndall. The function is where I find it helpful to think about the difference between, neurodiversity and something more that might be going on. So I wonder, just following on from that, like, how do we feel? What is our role with these kids that come in, who we're trying to explore what's going on, especially the kids where you've made a diagnosis. I've seen, I think, about 12 kids today. All of them had a diagnosis of either ADHD, autism, learning difficulties, those type of things. And if I'm being 100% honest, I think probably about 70% of them are struggling with mental illness. And I wonder, does anyone feel comfortable of like what our role is, especially in the kids where we've made a diagnosis? And I guess the traditional approach might be, we're just monitoring a lot of these kids, maybe seeing people that are doing 6 monthly reviews, just checking in, making slight modifications, how's everything going? I've only got 30 minutes, all of that stuff. But I wonder if anyone feels comfortable to think about what is our role, especially outside of that traditional medical model. I promise I won't ask as many questions the second half of the slides either. You can put something in the chat as well if you feel like.
Hi, yeah, I'm Mumanga.
Hi.
Yeah, hi. I'm doing a disc clinic at like one of Milton secondary schools. So I see like a lot of children, adolescent, like having behavior like issues, socialization issues. And then like they have like other than anxiety, one major issue is their learning and school refusal. So that's like, I'm always thinking, how can I improve their like a school attendance? How can you make the coming to school be a more comfortable place, like an enjoyable place? But it's very hard.
Yeah, and actually school refusal, I haven't got in this talk, but it's actually a beautiful example of like, there's nothing in autism or ADHD that means these kids should struggle to attend school. And so, we know that I see kids every week in clinic that still haven't returned to school since the pandemic. And, a lot of those kids, there is a clinical mental illness that's existing outside of autism or ADHD. So it's a really good point. and I think you're also talking to the role of the environment. We know ecological models help guide us towards like thinking about the child outside of just where they're sitting in front of us. And we might have time at the end to talk about where the evidence is in, improving things for these kids outside of traditional things like medicine. Just quickly, some of the answers that are on the chat are amazing. Kimberly, I'm the same as you. I often talk about with families, the first time I meet them is that I have 3 roles. One is the, medical hash of what's going on and assessment. I'm going to ask you lots of questions and I might, do some other stuff like that. Then I've got this role of advocacy, which is really about who else can come in and what else can we do. And then my third role is really what do we do about all this stuff? And most families actually want that third thing, and I think once we can skill up and feel comfortable in guiding kids from, behavioral problems, mental illness, anxiety, and all those things, and translating what we know from the evidence into something that's actually helpful for them in the consulting room, it can be really rewarding clinically. And yes, Sahar, unique strengths and support them to celebrate, help with their self-esteem. Yeah, I spoke about self-esteem, I reckon 8 times today, like specifically exploring how to build self-esteem in these kids, because it is a helpful way of thinking about that is something that is going to boost their functioning. It does address the need clinically. And I'm not saying it's going to replace SSRIs for all these kids, but it's an important component of it. And I think when we, feel confident in understanding where the evidence is in self-esteem is really helpful, especially from a developmental perspective. And then, yeah, Victoria, the family, that's really important. I think we miss that. And particularly in these kids, like, and people might have experiences personally with looking after children with ADHD or autism. They're gorgeous kids. I love seeing them in clinic. They can be really challenging parenting, and what we know is one of the biggest, barriers to these kids in terms of improving their mental health is parental mental illness. And so I think it's really important that we proactively protect the mental health of the parents with them. And there's lots of ways we can do that in the clinic and outside of it, but also we are screening for mental illness in the families. And Prakash, I wonder if you've got a comment about this, but a lot of, the work that Ben does, was speaking to Ben Goodfellow recently about this, and they have probably a much better way of thinking and feeling comfortable about talking to parents about their mental illness and those type of things. But maybe in case Prakash isn't here at the moment, we'll save that for the end. I'll just keep going. So just very quickly, and the reason I'm mentioning this is intentional. We all know this. Autism has 2 big components of a diagnostic criteria that are the clinical phenotype that we see, and the functional impact comes from these 2 things. It's really important to think about this, but also so that we remember when it starts failing to be just autism, the functional impact. And I wonder, restrictive and repetitive patterns of behaviors, maybe I'll open it up at the end of the session, but just thinking about how do we tell the difference between these kind of clinical features of autism and a child who has social anxiety, for example, or, avoidant behaviors, or OCD, or phobias, or generalized anxiety. And it's really important that we remember that, because I think sometimes we will say, well, they've got autism, so, I'm not surprised they're struggling to attend school, or they're really struggling socially. ADHD is similar, and I think a lot of the time there is a temptation, knowing how successful stimulant medication can be, in that this kid's really agitated. I think he meets criteria for ADHD. I'm going to try stimulant medication. A lot of young kids show us they're anxious through agitation, and it's really important that we think about it, because as we've probably all experienced, sometimes when you try stimulant medications for kids, especially young kids who have clinical anxiety and are agitated, you can have an outcome that means that they're probably unlikely to feel confident trying medication again in the future. And we might open up a chat about that at the end. So the important thing is this data is different wherever you get it from. The baseline general population rates are off the Lawrence paper in 2015, and you can see, it's 6.9% of the general pediatric population 4 to 17 years of age over a 12-month period has clinical anxiety, and 2.9 have depression. We know it's much higher. Deb Marks, who's phenomenal, people would know her, but she's been in this space for decades and says pretty much every child with a diagnosis of autism has clinical anxiety. And I think it's an important thing to remember that while some of the studies show us, yes, it's 40%, it's 60%, it's 80%, we should be thinking that they probably all that we see them, especially in clinic, that are having functional impairments will have an anxiety component to what's going on. And it's also really common in kids with ADHD. Depression is the same. And I think probably those of us that just purely have experience in pediatrics probably feel a little less comfortable with this than we do with kids with autism and ADHD and anxiety. But it's an important thing to remember that those kind of mood changes, difficulties with concentration can also be seen in depression as opposed to the baseline. So I wonder if anyone's got any comments about why they think there's higher rates and why is there so much comorbidity in mental illness and neurodiversity. Yes. Yeah. So yeah, we might get you to talk about that more, Prakash, but yeah, it's really common. But yeah, does anyone have any comments about why are children with neurodiversity more vulnerable to having mental illness? Give 30 more seconds for anyone to comment, and then I'll give why I think and what my interpretation of the evidence is. So we've covered a little bit of it. Yeah, lack of support and understanding. That's great, Jessica. Yeah. Beautiful, Victoria. Yeah, being asked to act in a way that's not true to how they feel and should act. And we know, yes, especially girls with ADHD in classrooms who are inattentive but not hyperactive, coming home and having a lot of mental anguish. We also know, as we've talked about with the parenting, social expectations, less distress tolerance, impaired problem solving, inbuilt problems with mood and affect regulation, neurobiological vulnerabilities. Yeah, so it's amazing, isn't it? Because when you think about, for example, autism, there are social and communication deficits, which mean we are less likely to catch them early in terms of understanding, and they don't fit the typical clinical profile of autism. It means that a lot of our screening tools will miss them. It also means they're more likely to be socially isolated. They're more likely to have low self-esteem. They're more likely, we're talking about this today, to be cognitively overwhelmed by meeting expectations that they really struggle with, which means that, their tolerance, as someone's talked about, their distress tolerance is lower. And so I think there's lots of different reasons. The societal expectation is a big one as well. We know, a lot of kids will really struggle with that. So yeah, lots of really good points. They're more vulnerable to being bullied. They're more vulnerable, especially from mid-primary school, to realizing that difference. That's when kids start to look around. We see the first peak in the second half of primary school of school refusal. A lot of that is normal developmental trajectories of trying to fit in and realizing they're different to other kids, and that performance anxiety that we see. And these kids are more vulnerable to those experiences impacting their mental functioning. I just realized I'm talking a bit too long. So I think I've only got another 10 minutes, but I'm going to keep going. So we all know this, but I think it's good to just kind of look at it closely. Both anxiety and depression have clinical features of difficulties concentrating. And I think it's important to think about the kid that we see that we might be a little bit too quick to diagnose either ADHD or say this is just part of their ADHD. One of the things that I try really hard to do in clinic is to make sure that I'm not sitting there, watching the clock going, God, I haven't got much time left with this family, and I'll just let my own bias sink in and start filling gaps in the story. Because I'm like, I've seen thousands of kids with this story. I know, let me guess, can't concentrate, is easily distracted. Sleep's pretty hopeless as well. And it's why we really should explore what else might be going on. And I think one thing we've kind of spoken about is that a lot of kids won't be able to verbally express, especially, if they have a reason such as social and communication deficits. They won't be great at having that internal capacity to kind of say, I'm really nervous when I'm around these other kids or things like that. And that social anxiety, or as Prakash has mentioned, that obsessive or compulsive behavior might look like it's something else that's going on. I wonder if does anyone feel confident talking about how you try and separate out, I think maybe it's my next one. Yeah, does anyone feel confident in how we separate out, you know, what might be going on in something like autism and ADHD and anxiety or depression? And for example, let's think about a child who has a diagnosis of autism, is in primary school, and he's avoiding something. Your family says, oh, he really doesn't like going near groups of kids. How would you tell if that's possibly a component of a social anxiety or part of the restrictive behaviours of autism? What would we ask families? Yeah, Dallas, awesome. So yes, baseline change. We know a big change, you know, depression, thinking about, you know, there's been a change in interest in activities that they previously enjoyed is a really important thing to screen for these kids, and knowing that change and saying, look, they were really, you know, but I've noticed their self-esteem is plummeting and now they're just not interested in things they used to be. That's really helpful. Does anyone else have any other comments? I think the baseline one's a great one. What would you particularly ask about if you're thinking, I'm trying to figure out if this avoidant behavior is in the moment? Does anyone have any comments? So I think it's really helpful to think about, you know, what does the child look like in those moments and what do we think is going on for them? And the child who might be doing it as part of their restrictive component of an ASD diagnosis. Yeah, and so yeah, that's good. I'll go to that in a second. The child who might be avoiding certain situations, who it is more of a restrictive repetitive behavior phenotype of autism, is usually doing it without significant levels of distress. And the anxiety won't always be verbalized in a typical way, but normally we can see that agitation or heightened arousal in these kids. That means that it is, you know, more of a process of anxiety that can be causing that avoidant behavior. And I guess that's what we're trying to understand for them, is that kind of agitation, arousal, fear system kicking off in their sympathetic nervous system, or is this more just a behavioral preference that they more likely to, you know, avoid social settings, loud noises, certain fabrics, all that kind of stuff that we see in restrictive behaviors of kids like that. And it's a little bit the same for the kids with ADHD, like trying to figure out, are they struggling to concentrate because it's something like anxiety? Dallas's point's a really good one. Has there been a change over a number of weeks? But also, what do we think is the kind of internal processes that this kid is struggling with? Is this something that is consistent across environments, has been for some time, but there isn't an associated distress? Or are we noticing that there are other things going on? One way that can really help to explore that is thinking about how do we reduce the burden that they have, which I think is my next slide. Yeah, and Sahar, how they react in different settings is really important. Often these kids, you know, one thing we struggle with is the families that'll say they're totally fine at home. What we've got to try and think about, is it because they feel safe and secure, or is it because they're not having the same kind of challenges in their environment presented to them from that kind of restrictive phenotype? I just know I'm about to run out of time and I want to have a little bit of time for questions. So I think the challenge that we have in clinic is we've got to think about, you know, accommodation versus skill development. And I feel like kind of everything that we do with kids who might have mental illness or even neurodiversity or neurodevelopmental diagnoses is thinking about this difference. And it can be really helpful. I talk to families about this. The accommodation stuff is what we do, where we're trying to kind of skill up educators to think about, actually, this child needs to be having movement, their stress relief is flapping their hands or doing whatever they need to from a sensory motor behavior component. We all see the kids who have ADHD in the clinic that need to have a lot of stimulus. So I still remember a kid I saw quite some time ago now that the teacher figured out all they needed to be able to focus was for the duration of a class, was to go up and touch everything on the teacher's desk. And they just had this sensory need that if they didn't do that, they'd be completely overwhelmed. But then also, you know, thinking about where the skill development is, and most of the young kids we know, we might get a chance to talk about this more, especially younger than primary school. A lot of the evidence is in psychoeducation and parent training, and that can be really challenging for us to access. But I think we can do that in clinic if you feel confident with it about what are developmentally appropriate expectations and responses to kids that are having. And school refusal is a perfect example. If there's an expectation that these kids will go back into that environment without some level of accommodation and skill development, and we're kind of all kidding ourselves. And often those kids will go in and either, you know, catastrophically fail, or they'll go in and hold and tolerate a level of distress that we're not aware of because there's that expectation that they should. And that's kind of where then therapy comes in. There is evidence around certain therapeutic approaches for kids with autism, ADHD. There's less evidence, but it is important that we understand they have to be delivered by people that have experience and an understanding of how that should be done differently. And then I think that idea about, you know, the skill development and the accommodation both thinks about how do we build capacity and skill development. And I've put reduced burden on the skill development side, but it should be on the accommodation side. How do we decrease what this child has to overcome to succeed? There's a whole lot of resources. Let me just see. Yeah, so I think that's the challenge, is that kind of mix of skill development and inclusion with addressing the actual needs and the deficits that are occurring in these kids. I've just been given notice that I can have a little bit more time, which is awesome. And I actually want to just open up the group to use that time, actually. This is just some work that we do as part of a Churchill Foundation and a social enterprise, just in using social media to really build capacity in kids. And we have a podcast and Instagram pages that are used for that. We find it gets used a fair bit by professionals, which is amazing to hear and always makes me a bit nervous. But just in terms of, there's lots of stuff about anxiety, depression, kids who can't focus, neurodiversity. We've just done one on developmental trauma that's kind of gone through the roof. So if people find that helpful or have any feedback about it from this group, I'd find that really beneficial. And then I think, yeah, that's my last slide. So I'm just going to intentionally bring my screen off. And I wonder if, does anyone have any questions or comments about kind of exploring that? It's hard to cover in 30 minutes, but hopefully some of that was helpful and provoked a bit of thought. And then obviously we're going to go through the case.
I just want to add how amazing your podcast is, because I have been following it since the last time you were here, and I have learned so much as a parent and a health professional both.
Oh, thanks. That's lovely. Yeah, it's a lot of fun. I feel like sometimes I'm just doing it because I like talking so much, but it seems to be helpful. But yeah, I wonder if anyone has any questions or comments about kind of the situation that we face clinically in kids that will come in and we're trying to explore. You know, I've got a child who I think it might be autism and ADHD, but I'm trying to figure out if there's anxiety as well. Or I know the one diagnosis is there. I know this is really common in lots of kids, but I struggle to tease it out. Does anyone have any comments or questions about it? Prakash, do you have any, I mean, you've taught me a lot about this stuff as well.
No, I mean, I think the important thing is to understand these kids. It's never going to be easy to differentiate pathology from physiology in neurodiverse children, and sometimes you have to kind of engage them with the aim of understanding them, and through that provide them with the interventions they need to manage existential anxieties and other problems on a day-to-day basis. The less likely you are to see them as disordered or disabled, the more likely you are to be able to look at strengths and engage them in therapeutic ways, which will help you make gains with them. So I think that that's an important thing, and that's exactly the opposite to what the NDIS sort of system requires of us. Yeah.
Yeah, I'm sure all of us, to some extent, have to play the NDIS game, but it can be really hard. And I'll be quite open with families about that, to be honest. That, what I'm having to put in reports is different to the conversations we've had and things like that. Yeah, but I can think of an example recently where, trying to figure out in the schools struggling about OCD versus, a child who has autism, and trying to think about what's going on and just really repetitive fixated behaviors and trying to explore that. And it can be really challenging, but I think, trying to understand of, how compulsive is it? How much is this something that just preoccupies this child's functioning? And, the great thing about the way that I think one way to practice this is that we're just testing hypotheses. There's a lot of fellows in clinic today, and they were struggling with some really complex kids and saying, look, I don't know, we've started risperidone, we're doing this. I don't know if it's working, mum says it is, teachers say it's not. But what we should always be doing is openly exploring hypotheses and thinking about, this is what we think might be going on. We are going to explore and think, is this OCD that is causing these kind of behaviors that are really causing a lot of dysfunction in your child? And we're going to trial a treatment for it, but we're going to be watching and make sure, and the evidence will be in improvement in functioning. And we should feel confident, having those conversations in an open way with families, instead of saying, well, I'm 100% certain it's OCD, this is the treatment and it's going to work. But it can be really challenging doing that. Yeah, if no one has any questions, if anyone wants resources about this, please feel free to reach out to me. There's a number of resources, but they're just quite long. That can be really helpful about evidence-based practice, measurement tools in kids with neurodiversity that are helpful for screening, different approaches. The UK has some guidelines that they've put out about how we should approach this clinically. It kind of talks to what Prakash is talking about. We should understand that it's difficult and be really curious to explore what might be going on, but it kind of goes a lot deeper than what we can in a kind of 30-minute chat. So please feel free to reach out to me about that.
Just trying to share something. Question. Yep, you can unmute yourself. You had your.
Hello. Is now an appropriate time for me to ask you a specific question?
Yeah, go for it, Dallas. Yeah.
Cool. I'm a social worker, and I'm working with a 12-year-old who definitely neurodivergent, no diagnosis, certainly anxiety, and recently reported hearing multiple voices that are not their own, some familiar, some not familiar. No one else is around to hear them. So I did a referral through the RCH. And when I spoke to the intake worker, her sense was the young person is neurodivergent, and this isn't like an auditory hallucination, but him struggling to differentiate his internal voice. And I haven't experienced this before. How do I know the difference?
Really good question. I'm going to go before Prakash. And I know he'll be
Sorry, it's a
delicate
specific
enough.
question, everyone.
No, it's Dallas. It's a great question, and you know what? It actually reinforces what we've already spoken about. So, I think one of the things when we hear about those things is what we think about is distress and dysfunction. So, if a child is kind of, how old did you say they were? 12. Yeah. So. Yeah, I can remember with Prakash, actually, I think it was one of the other psychiatrists, but seeing a child on the psych ward that was having a lot of kind of what seemed like auditory hallucinations, but being, very comfortable with them and functioning very well and not distressed. And, and so I think people were a lot less worried about them being, early psychosis, schizophrenia kind of profile. I think that with that child, what would be interesting is thinking about like what the impact is functionally, but also is it occurring across environments? What's the kind of anxiety overlay that's existing within that? And what would be really important is to treat that and optimize how everything else is going. And then you would actually explore and see how they go. But it is quite unlikely, in that profile. But Prakash, what do you think?
Yeah, I would take the approach that this child is probably not psychotic at the moment, but that he may be at risk of developing psychosis that is slightly higher than the general population. So I would agree that the important thing would be to treat the current, other symptoms like anxiety and other things quite effectively, because by doing that, you can actually prevent a psychotic breakdown. So that's a very, very important thing to remember. Yeah. And the treatment of the anxiety may involve low-dose antipsychotics, but that is not the antipsychotic level dose you would use in somebody with frank psychosis. But even that may be useful sometimes. But other techniques like psychological techniques and other techniques, and I often say this, that young people with ASD might respond better to some occupational therapy input with sensory sort of interventions initially before they are able to engage in psychological therapy proper. So that's another thing to keep in mind.
Yeah, it's a really good point, actually, because a lot of we feel comfortable saying that with younger kids, an OT would be better about delivering therapy, but a lot of kids who, especially those who might have an intellectual disability as well, which is about 50% of kids with an autism diagnosis or who have social and communication deficits, then the non-talking therapy can be really helpful. But it's a great question, Dallas, and I think one thing that would, if they've been going for a significant amount of time without a lot of distress, I would be less worried and still just focus on the anxiety as well. So whereas if, child's really struggling with them, there's been a real significant worsening in function at the same time that the kind of voices started or the query auditory hallucinations, then we would be more worried clinically.
Amazing. Thank you.
Yeah, no problem. Great question. Does anyone else have any? The hairier, the better. Or do we have to actually start the cases?
If there are no questions, I would like to go to the case studies and then we can have discussions while we are doing those. So just a sec. Just about the health pathways, everyone, there is a really good section on neurodiversity. We have explored that in previous sessions as well, ASD, ADHD. So please feel free to go and have a look and give feedback when you can. I'm just going to go to case study for now.